Thank you for joining the webinar. Thank you especially for our presenters.
Thank you very much for asking me to talk at this seminar. And yeah, I'll talk about the James Lind Alliance that Carthage mentioned in his report. I'll try and flick through these slides relatively quickly because I'm conscious that we may be a little bit short of time. But just to explain to those of you who might not know, who is the James Lind Alliance? We are a very small organization in the sense that there's only about 3 part-time support staff that are hosted by the National Institute for Health Research. But beyond that, we have, of course, dear old James Lind, who we'd named the organized or the sort of community after. And James Lind was a Scottish naval officer. And the reason we use his name is because he's one of the first people who we believe actually conducted a proper clinical trial. James Lind tested different remedies for the sailors who had scurvy on the boats and discovered that indeed citrus fruits work much better than cider or sorts of other things that he tested on them. And oranges and lemons were the key to helping with scurvy. And it is reported that that was actually the start of the mafia, because the mafia picked up on this newfound trade of lemons from Sicily and indeed started brokering business that way. So we deny any connection to the mafia in our organization, however, but James Lind may well have kick-started it all off. In terms of what we've actually done with the James Lind, Sir Ian Chalmers is, along with Nick Partridge and John Scadden, started the James Lind Alliance back in 2004. So we have been going for some time. And along with those 3 who started it, we currently have 5 advisors who work with groups of patients and clinicians on James Lind Alliance partnerships. And of course, we have all the priority setting partnerships who have got together to set research priorities together. So current partnerships include a massive list. So we have had quite an extensive impact already in the UK and internationally. Several of our partnerships are spread across the world. We're working with the Netherlands, New Zealand, Canada, and so on. We've been asked for collaboration by Norway as well. So we're moving along. So why the JLA? Well, the reason Sir Ian started James Lind Alliance is that he realized that there are other research priorities than what normally gets decided by researchers and by the pharmaceutical industry. The priorities of people who have different conditions and the people who treat them and care for them, those priorities can be very, very different to the priorities of pharma industries and even researchers who are, of course, well-meaning. So what do we do? So what you're probably really interested in is what we do and how we do it. We work together with patients and clinicians together as equals to identify and prioritize unanswered questions that they have on health and care. So it's basically people with lived experience, patients, carers, relatives, and professionals who look after them. The good thing about this is it also reduces wasted research. You'll be aware probably that Sir Ian wrote a paper back in 2009 with Professor Paul Glacieux, recognizing that actually up to 85% of research funding is wasted simply because of all of these factors. And one of the more important initial factors is that clinicians and patients aren't involved in setting research agendas. So we're not creating research questions that are relevant to clinicians and patients. It's not to say these are the only questions that we need to look at, but it's just an alternative, an additional agenda that we need to look at. So how do we do it? Well, it's very simple, really. The principles are, as Carthage quoted from the other projects that he's reviewed, and they're very much around inclusiveness, methodological transparency, and using and contributing to the evidence base. So we are trying to be as evidence-based as poor old James Lind was in actually doing this as scientifically as we can. The process is up on your screen. And basically the process, we have a startup phase when somebody has an initial idea. So these are natural groups that form out in our community of patients and professionals who decide that, hey, we want to actually research some of our ideas. When Sir Ian started this, he had been talking to people with rheumatoid arthritis. So this was back in 2004. And as a clinician, he had assumed that these people, their main concern and complaint was pain. And clearly pain is important. But in fact, the patients told him that what concerned them was fatigue. So that was the initial idea, and that's where Sir Ian actually started the James Lind Alliance, working with these patients, thinking, hey, they've got a different research agenda. So these initial ideas just happen naturally out there in the community, and people get together, and then they come to the JLA central team and say, we want to start up a priority setting partnership. And they set up a steering group, agree the scope of their project, and identify partners that they can work with. We then move on to data collection, and this is the basically we go out and consult with the wider affected groups, so the wider group of patients, people with lived experience, and professionals who have an interest in this particular condition. And usually that is done by an online survey. We use online tools like SurveyMonkey or other tools. Occasionally run workshops and have paper surveys too when necessary. And as Carthage said, it is as simple as can be. We basically ask people to tell us, what are your questions? Sometimes we help them a little bit by suggesting areas that they might be thinking about, but it is within this, whichever health condition that we have been looking at. So we collect people's questions and we harvest these from literature, and then we move on to the data analysis phase. Now, I put an indicative time scale on the slide. It is just indicative. It can vary a lot depending on how many responses we get, how many questions are submitted to the partnership, and how complicated the data is. This is very, very unpredictable. It's one of those things that we just don't know. Sometimes you might only get 100 questions. Sometimes it might be thousands. Out of all those questions, a little bit like I think it was the Dutch process, which clustered the questions down to 248 clusters. Well, we do a similar thing. We group similar questions and create clusters of questions and form summary questions. All of these questions continue to be formed in lay language. These are not research questions. We do verify that the questions have not yet been answered by research, that they are indeed unanswered. And from those summary questions, we do agree a long list of questions, which we then put out again to the wider audience, the wider community out there, through, again, usually online survey tools. So we ask them to prioritize a long list of, say, 80 questions to come up to a short list of 20 to 25 questions. So this is all kind of wide consultation, wide user base. And then we have the personal at the final prioritization day, where we have a face-to-face meeting, a consensus workshop, where people prioritize the short list of 20 to 25 questions and agree the top 10. And the idea with this is that we're getting a wide range of inputs and sometimes really insightful questions, which is fantastic. And then none of those questions are lost. We keep a record of all of those questions, and all of the questions will go to the funders. But the top 10 is kind of it's kind of a publicity mechanism as well as indicating what is top. What are the top 10s? The top 10 is also a PR message for people to say, hey, this is what people have said is important to them. From those top 10 questions, we can form research questions together, working with the funders, research funders, and research institutes. And quite often papers, publications are result from this as well. Just a couple of examples here. We gather questions using online tools. So I've got a link here, for example, to a tool that's an online survey on hypertension in pregnancy, which we have put out. All of these links are available from the James Lind Alliance website. And we ask very simply, whether the person is somebody with lived experience. In this case, we include their partners, husbands, and other partners, and whether or not they're professional or in fact a researcher or something else, somebody just with an interest. And then the questions are very simple. Oh, I need to actually answer something. I'll say I'm a researcher. And the next question is very simple. What is your first question? We want to know about what the top 3 questions are about high blood pressure, and the order of the questions doesn't matter. We just want their questions. So that's the general nature of our surveys. So every partnership can decide how they lay out their own surveys. If we go back to this, what's the sort of response we get from these surveys? There's some examples here from recent surveys that we've done. You can see sometimes the amount of data that we get in terms of submitted questions can be large. So the data analysis phase is indeed, quite tricky for some of them. We go through the data analysis, and as I think I mentioned, we prepare the data set. One of the things that we do is remove out of scope questions. That's why the definition of the scope of the survey is very important. Quite often, partnerships don't want to look at actually service organization or access to services or things like that, because they tend to be kind of policy questions as opposed to science research questions. But some partnerships do include those because they think they're important and are worthy of research. So it varies. And we format them into summary questions to get to the long list of 80 questions. The sort of way that's done, there's an example here from scoliosis. You can see that for the top summary question, M2, does diet have an impact on scoliosis? There were a number of questions that were submitted that contributed to that. And the code on the right indicates whether it was a healthcare professional or a patient or a relative who submitted the question. And then, as I said before, yes, this phase takes time, and partnerships are typically taken between 2 and 6 months to complete that phase. The interim prioritization is relatively easy once we get through to the shorter list of questions. And here's an example from another survey. This is about safe care for adults with complex health needs. So this is the 80 or so questions. I don't know quite how many they had to start with. And we asked the wider public to use this survey tool to pick their preferred top 10 questions to try and shorten the list of 80 questions to a manageable list that we can take to the consensus workshop. There are a number of tools that we can use, thank heavens, online, but we do have workshops and face-to-face meetings with target audiences where they can't access the internet or don't wish to access the internet. So we just have to be inclusive. I think one of the things to bear in mind is that for the James Lind, this is about inclusiveness, but this is not a scientific research exercise. We consider this to be consultation and seeking some new insight. We are not always able to reach all participants. We have to work within the resources that each partnership has to their hands. They get their funding from charities or from whatever organization, and they may have a limited budget and limited resources. So we reach out where we can, but there's no pretense that we're being perfect, comprehensive, or anything like that. But we are very transparent about what decisions we make about who we reach and how we reach them. And the main aim is really just to get some new insight, even if we don't reach absolutely everybody. But the idea is to be as inclusive as possible and always work on an equal footing. And that is well represented at our final consensus workshop again, which is a day of democratic discussion, quite a lot of hard work. We have up to 30 people with lived experience, carers and professionals in equal numbers to prioritize the shortlist of 20 to 25 questions and agree the top 10 priorities. This is what a final workshop might look like, and at the end, the picture at the bottom shows relatively happy people who survived the day, showing the top 10 questions on the pink card that they have prioritized. And from there, those questions will go out to funders and to the National Institute for Health Research and so on, to actually get some research agendas and calls for research organized around them. So what happens? Do we get anywhere? I think we've had some good results. And as Carthage indicated, that evaluation is still, we haven't really looked that hard at the impact. It is not easy to look at the impact, but we try and track what we can. And we are just about to start in 2019 a big evaluation study of the James Lind Alliance and its impact. But up until now, the sort of impact we've had is that you can see here, we've had £2 million of funding into a particular question, question number 10, priority 10, in schizophrenia, apologies. In the Sight and Loss Vision Partnership, they actually had 12 categories of eye conditions that each had 10 top priority questions and £6.5 million for that. Palliative and end-of-life care, we had £1.5 million by Marie Curie to fund high-quality research into the 10 top questions. So we do get results. The challenges, as you can imagine, doing this frontline kind of work is engaging with people with lived experience and professionals to get their time and their commitment and input. It's not always easy, especially with people who are frail or unwell, to get them to participate and to be able to do so in an inclusive and accessible way. The data is difficult, it's unpredictable, and it takes time. Typically, a peer partnership will take between 12 and 18 months from start to completion. And what works, it clearly is having a good steering group. Getting this right at the beginning is really worthwhile. We usually have a steering group of between, 10 and 20 people. So we have an application. Having good partners who can help publicity in terms of getting the surveys out there into the wider communities, the wider affected communities, and keeping the scope clear, keeping ourselves, sort of, so we've always got a check that we can go back to and say, okay, this is what we're actually looking at, because you can have scope creep very easily in these projects. It gets very exciting. If you'd like to join the JLA, you can do that internationally, and for more information, please come to our website. We've got all the links there to all the stuff I've been showing, or contact me either on Twitter or by email. Thank you.
Thanks, Toto. Fantastic work you are doing. And I think with potentially a great overlap to the challenges that a project like HPP will have, or an infrastructure in the future. One thing I came to think of is, which has been a discussion elsewhere. For example, there was a workshop in DG Research about open research agenda setting recently, and there was this discussion about reuse of the input you get. I mean, do you look at when you set up such a process, do you look at it as something which ends up with the priority list and the result, and then you start up a new process and forget about the results you got before, or do you look back? Do you dig up ideas and see if they begin to be relevant, or, well, what do you do with things you did before?
So you were asking about reuse of partnerships that we've worked with before who've come up with questions. Is that correct?
Yes, because for example, here you make 80 questions, you put down so shortly for 20, and then you end up with 10 prioritized. But it might be so that out of the 80, some of them were not prioritized because they might have been premature or something like that, and then at a later stage they might be relevant again. So do you take a new look at what you did before sometimes?
What we encourage any new partnership to do is to look across any of the other questions in case there's overlap. So in that way, we always reuse the questions to make sure that there's, if there's any overlap. So for example, I'm working with the vascular partnership looking at vascular conditions, and they're looking at some of the questions for diabetic partnership and other partnerships where there might be relevant questions. in terms of whether we look at actions, the James Lind Alliance is simply the facilitator. Our role in the partnerships is to act as the neutral facilitator to keep the peace, make sure everybody has an equal voice, and try and keep the project to time and keep it honest. So it is the partnerships who go back to look at their questions and consider whether or not they might, whether any of the questions that were lower priority might now become more important. So we have to leave it up to them, because we cannot, with our staff, actually track. We've got 60 completed partnerships now, so we cannot track all of the questions and how those are progressed. And we don't really have a strong role in pushing those questions for funding. We simply allow the partnerships to work with the NIHR and do that. However, in terms of the evaluation work, that will look at the questions and see if other questions have been looked at. And the other thing that we do is that we keep an archive of all of the material, which is publicly available and always available to new groups or people who are interested. And all of the questions are there, including the audit trail. As again, Carthage mentioned about one of the projects, we have the audit trail back to the very original question that was asked. We don't have a link to the original questionnaire because it is anonymous, but we have the audit trail to the original questions that have been submitted, which does help researchers think about what was the real intention behind the summary question that they've seen. So none of the questions are lost. They're always available. And indeed, our funders, researchers, the charities who fund these programs, they're always interested in all of the questions.
Yeah, I can imagine. That's a gold mine for input and for overview of how people look at things.
Oh, yeah. Yeah.
Okay.
Really fabulous.
Input, questions, comments to Toto? Okay, we have from Philip, because Philip is on the phone. He wrote that I would be interested as well to know the human resources necessary to run the agenda setting process you run. How much?
So human resources.
How much time do you throw into it?
Okay, how much does it cost? Typically, it takes about 8 to 10 steering group meetings to get through to a conclusion. And those meetings are between, 2 and 4 hours per meeting. A lot of them we run by teleconference because the patients and professionals and myself or one of the other advisors, we're spread all over the country. Sometimes they're face-to-face. So that gives you an idea of the kind of time commitment of just the participants in the steering group. In terms of working together. In addition, I indicated that for the data section, the data scientists, the information scientists working on that, I think full-time would probably take a couple of months, or if they're part-time, 6 months. So whatever your information scientists cost you, it's a significant chunk of time. The coordinator for a group like this obviously spends more time outside of the meetings, arranging meetings and notes and preparing surveys and doing online work. So the partnerships, depending on what resources they can kind of assume from a, quite often it's staff costs that they don't have to pay directly because it's staff who are doing the work. But typically a partnership like this can cost between £10,000 and £50,000. So as we're nearly the same as the euro, that's 10 to 50,000 euros, depending on how extensive their work is. They try to, obviously minimize survey costs and printing costs and things like that, which can be quite significant by using digital tools. But if we have face-to-face workshops, they have a cost attached.
Yes. I think that fits with experience we also hear from Simulact, that this is work. It's not just something you can take easy. There is work to be done, but I also think it was interesting to see that some of your one thing you put up as an important reason was to avoid wasted research, which I think is really a challenge in this world. That should be focused on. Any other questions, comments to Toto?
So this is Carthage. Can I just ask about the link to funders? So how do you really make sure that these questions have an influence on the research agenda? So have you got formal agreements with funders, or is it just sort of all informal, or does it work via the coordinators, or how exactly does that work?
Good question. The answer is probably all of the above. The National Institute for Health Research is now quite committed to supporting or looking at whether or not a funding application, for example, has been through a James Lind Alliance process or represents one of the priorities of a James Lind Alliance process. In any case, all applications need to demonstrate how they've involved, sort of target communities. But the James Lind Alliance does get a big tick when applications or research calls go through a funding review. Within the sort of government funding, yes, it is important. Within the sort of charities or groups like that, it is more informal. It's entirely up to the charities on how they look at it. But we're getting to have a growing kind of influence in terms of the research questions that we come up with, which is good. Which is good news. But it's a mixture of all of the above, and we're working on it. Any top tips welcomed. We will be looking at your reports too, experience from other countries. So thanks for that.